Good afternoon, class. In this recording, we're going to take a look at acute kidney injury or acute renal failure. Acute kidney injury is often reversible. It is responsive to shock, acute illness, or injury. It can progress to chronic renal failure. Its onset is sudden. It involves 50% of the nephrons and lasts usually less than 3 months, but it's usually 2 to 4 weeks. The prognosis is good for return of kidney function. However, depending on the cause, we see a high rate of mortality associated with acute kidney injury. Causes of acute kidney injury can be associated with 3 types: pre-renal, intrinsic, and post-renal. Pre-renal conditions are conditions where we have decreased blood supply. Intrinsic are where we have physical, chemical, or hypoxic or immunologic damage. And post-renal is where we have obstruction of the collection system. So some examples of pre-renal acute kidney injury: shock, any type of shock, hypovolemic, hemorrhagic, heart failure, pulmonary embolism, anaphylaxis, sepsis, and pericardial tamponade. So any condition where we have decreased blood flow to the kidney itself. Intrarenal or intrinsic are where we have actual physical, chemical, hypoxic, or immunologic damage directly to the kidney tissue itself. Some examples include exposure to nephrotoxins, acute glomerular nephritis, which we're going to talk about that in a little bit in another recording. I think we've already covered that. Acute interstitial nephritis, vasculitis, tubular necrosis, renal artery and vein stenosis, renal artery or vein thrombosis, which leads to the kidney itself not getting oxygenated blood, and formation of crystals and precipitates in the nephrons. Some examples of post-renal conditions include ureter, bladder and urethral cancer, kidney, ureter, and bladder stones, bladder atony, prostatic hyperplasia or cancer, urethral stricture, and cervical cancer. So anything that happens down here below is what's going to lead to the post-renal. The criteria for classification of acute kidney injury is based on 5 rifle categories of changes in the glomerular filtration, serum creatinine, and reduction of hourly urine output. So rifle stands for risk, injury, failure, loss, and end for end-stage renal disease. These criteria apply to patients with no known kidney problems and to patients with chronic kidney disease. The first 3 criteria, RIF, are injury severity levels. Identification of AKI at these levels and proper management can prevent progression to more serious injury that may be irreversible. The last 2 criteria, LE, indicate serious injury that requires renal replacement therapy, at least on a temporary basis. Even at level L, some people have return of kidney function. So with the risk, the severity risk level, we have the creatinine will increase 1.5 times above the normal, or the patient's normal with chronic kidney disease is known to exist, or with injury we have increased 2.5 times, failure 3 times, and so you can see the progression there with the creatinine. The glomerular filtration rate will be decreased by 25% at the risk level, at the injury 50%, and decreased by more than 50 at the failure rate. And then the urine output is going to decrease depending on the level. So at the risk level, it's 0.5 milliliters per kilogram per hour for 6 hours. And then for injury, it's less than that every 12 hours, and then it's less than that every 24 hours. So the rifle is a good classification system. With the loss level, there's complete loss of kidney function that persists for more than 4 weeks, and at the end stage, the loss of kidney function persists for more than 3 months. So this is just a good way of classifying and recognizing when the patient's kidneys are starting to decline and trying to take some action. There are 4 phases of acute kidney injury. The onset stage. The onset stage is sudden. It lasts for hours to days, and it's characterized by an increased VUN and creatinine, but with a normal urine output. Primarily, treatment during this stage is reversible to prevent damage. The second phase is oliguric, and the urine output decreases to 400 a day, and the serum BUN, creatinine, potassium, and phosphorus increases, and the calcium and bicarb decrease during this stage. The diuretic phase begins when the urine output exceeds 400 cc's a day and can actually rise to 4 liters a day. Although large quantities of urine are being produced, not a lot of waste are being excreted during that phase. Toward the end of the diuretic phase, the kidneys start to excrete more waste products, and this is an indication of returning to normal function. And then there's the recovery phase where the labs begin to return normal. And this can last from 1 to 12 months. So key features of a client in the pre-renal phase, some of the key signs and symptoms are listed here, and some of the systems that are actually impacted during the intrinsic phase. There's a number of features relative to the intrinsic phase. And so you can see here virtually all systems are impacted during this phase. The renal manifestations can include oliguria and anuria, increased urine-specific gravity for the intrinsic types of acute kidney injury. Cardiac manifestations can be hypertension, tachycardia, jugular vein distension, increased venous pressure, and EKG changes. Respiratory changes are all around the fluid overload, so we're going to hear crackles, we're going to see symptoms of pulmonary edema, shortness of breath, orthopneic, and so forth. GI symptoms, anorexia, nausea, vomiting, flank pain, neurologic. As the waste builds up and the ammonia builds up, and we see lethargy, headache, tremors, and confusion. In general manifestations, we might see weight gain and edema. So what can we do to prevent acute kidney injury? We want to maintain a euvolemic state where we have a balance of intake and output. We want to provide early and adequate volume expansion with isotonic crystalloids, maintain a normal glycemic control, particularly in the critically ill, ensure adequate nutrition, limit diuretics, avoid low-dose dopamine. Studies have found that dopamine is associated with more dysrhythmias and high risk of death, so we've got to avoid those. And monitor our aminoglycoside levels because they can also contribute to this condition. Medical treatment, Supportive measures are aimed to control symptoms and prevent complications. Supportive measures include fluid and dietary restrictions, restoring electrolyte balance, and dialysis if needed. So the drugs depends on the stage. If they're in oliguria, they're treated with diuretics, usually mannitol or Lasix. If their potassium's high, they're treated aggressively for that. Drugs to lower potassium include hypertonic glucose and insulin, sodium bicarbonate, and calcium gluconate. K-Xlate is also used to get the potassium down. Diet modifications are based on their individual situation and their electrolyte levels. TPN may be prescribed if the GI tract's not functioning. Fluids, daily fluid totals are usually calculated by adding up their intake and looking at their previous day's output and trying to balance that out and maintaining fluid restrictions. Dialysis occurs if they fail to get control of the potassium or if they're in severe metabolic acidosis. Metabolic acidosis is the problem we're worried about more so than anything with acid-base balance. And they may be also put on an option called CRRT, and we're going to talk about dialysis and CRRT in another recording. So those are some other treatment options. So with nursing care, it's imperative that you maintain intake and output, daily weights, monitor their electrolytes, maintain a euvolemic condition with the patient by adjusting the intake based on the previous day's output, administering medications as prescribed. Closely, again, monitor electrolytes. You might want to look back over your fluid and electrolytes, particularly your hyperkalemia, because they're going to have high potassium, and you need to know what to do relative to that as well. This concludes this recording. I thank you very much.